Common mental health issues, neurocognitive disorders, classifications in the DSM-5. As always, all of the technical information in this PowerPoint comes from the Diagnostic and Statistical Manual of Mental Disorders as published by the American Psychiatric Association. I have added some of my own commentary as it relates to this course. I have highlighted several of the most common diagnosed mental health issues that may present in your clinic, office, classroom, or other place of work, and it will vary depending upon the population that you encounter. Something I want you to keep in mind as I go through this PowerPoint is that the DSM is a categorical way to look at mental health issues. It is included here so that if and when a client or patient comes into your office or clinic or practice and states they have been given a diagnosis of a disorder, you have at least a rudimentary idea of what they mean. I am on the side of depathologizing and destigmatizing mental health issues, and I encourage all of you to seek to find out what may be driving the behavior that has been categorized or compartmentalized into a set of criteria. Expressed behavior that fits a diagnosis can be looked at as an adaptation or experience of life events that may have felt overwhelming, chaotic, and sometimes even life-threatening. Learn about these definitions, diagnosis, and criteria. It is important, but always keep in mind that you are working with a person. You have a working relationship with that person who may have had to learn different ways to cope in less than ideal circumstances. Please stay curious about the person, not just the condition. I am going to briefly describe neurocognitive disorders, but for more information, I suggest that you search Library for Research articles, look for textbooks and other material sources for a well-rounded look at many of these conditions. So I'm going to start with delirium. An essential feature of delirium is a disturbance of attention or awareness that is accompanied by a change in baseline cognition that cannot be better explained by another pre-existing neurocognitive disorder. There may be associated disturbances in the sleep-wake cycle, which can include daytime sleepiness, nighttime agitation, difficulty falling asleep, excessive sleepiness throughout the day, and wakefulness throughout the night. Some risk and prognostic factors include environmentally, delirium may be increased in the context of functional impairment, immobility, history of falls, low-level activity, and use of drugs and medications that may have psychoactive properties, including alcohol and anticholinergics. Older individuals are especially susceptible to delirium compared with younger individuals. In childhood, remember that delirium may be related to febrile illness with certain medications. So major and mild neurocognitive disorders are primarily subtyped according to the known or presumed etiology or pathologic entity or entities underlying the cognitive decline. The subtypes are distinguished through combination of time, course, characteristic domains, and associated symptoms. These disorders exist on a spectrum of cognitive and functional impairment. The core features of neurocognitive disorders are acquired cognitive decline in one or more cognitive domains, one's concern about cognition on the part of the individual, a knowledgeable informant, or the clinician, and to performance on an objective assessment that falls below the expected level or that has been observed to decline over time. Risk and prognostic factors vary not only by etiology, but also age of onset. There is a strong risk factor for major and mild neurocognitive disorder, and that, of course, is age, primarily because age increases the risk of neurodegenerative and cerebrovascular changes or disease. With Alzheimer's, there is major to mild neurocognitive disorders due to Alzheimer's disease progression. It's gradual. Sometimes there are brief plateaus through severe dementia all the way to death. The mean duration of survival after diagnosis is approximately 10 years. The onset of symptoms is usually in the 80s and 90s, with early onset forms seen in the 50s and 60s. A diagnostic marker is cortical atrophy, amyloid predominant neural plaque, and tau predominant proteins. There's neurofibular tangles, which are hallmarks of Alzheimer's and may be confirmed via postmortem histopathological examination. Frontal, temporal, Lewy body, and vascular. So frontotemporal, major to mild neurocognitive disorder comprises a number of variances characterized by the progressive development of behavioral personality changes and or language impairment. This disorder commonly presents in the 60s, although age of onset varies anywhere from the 30s to the 90s. The disorder is gradually progressive, with median survival being 6 to 11 years after symptom onset and 3 to 4 years after diagnosis. The survival rate is shorter and the decline is faster in this disorder than is typical of Alzheimer's. Computed tomography, CT scan, and other types of neural imaging may show distinct patterns of atrophy. Lewy bodies, a diagnostic feature of major or mild neurocognitive disorder with Lewy bodies, corresponds to the condition known as dementia with Lewy bodies. This disorder is not only progressive, there's cognitive impairment, but also may include visual hallucinations and recurrent symptoms of rapid eye movement, sleep behavior disorder, as well as hallucinations in other sensory modalities, depression, and delusions. There tends to be a gradual progression of the disorder with insidious onset. When we talk about vascular, there is also major and mild vascular neurocognitive disorder, and it can occur at any age, although the prevalence increases exponentially after the age of 65. The course may vary from acute onset with partial improvement to stepwise decline to progressive decline, with fluctuations and plateaus of varying duration. This disorder is a vascular brain injury and influenced by neural plasticity. The factors are like education, physical exercise, and mental activity. Those are the things that kind of keep our brains healthy. The major risk factor for this disorder are some of those that are the same as for cerebrovascular disease, which include hypertension, smoking, diabetes, obesity, high cholesterol levels, high homocysteine levels, other risk factors for atherosclerosis and arterial sclerosis, atrial fibrillation, and other conditions that can increase the risk of cerebral emboli. Traumatic brain injury, substance or medication-induced, and HIV. With traumatic brain injury, a diagnostic feature is, of course, the impact to the head or other mechanism of rapid movement or displacement of the brain within the skull, as can happen with things like blast injuries during military conflicts, war, artillery shooting large weapons. Specific characteristics that include in the diagnosis of TBI is loss of consciousness, post-traumatic amnesia, disorientation and confusion, and in more severe cases, neurological signs such as positive neural imaging, new onset of seizures or marked worsening of pre-existing seizures, visual field cuts, anosmia, hemiparesis. There can also be cognitive presentations, but those can be variable. Difficulties exist within the domains of complex attention, executive ability, learning and memory being common, as well as slowing in the speed of information processing and disturbances along with social cognition. There are varying severity ratings associated with TBI from mild to moderate to severe. Substance or medication-induced. Diagnostic features of substance or medication-induced major or mild neurocognitive disorder is characterized by impairments that persist beyond the usual duration of intoxication and acute withdrawal. These manifestations can reflect slow recovery of brain functions. This can be from prolonged substance use, and improvements in neurocognitive as well as brain imaging indicators show this can happen over several months. The prevalence of these conditions is not known. Commonly, substance use begins during adolescence and peaks in the 20s. So the older someone is when they attempt to stop or eliminate the behavior is associated with a greater likelihood of neurocognitive disorders. However, the relationship is not straightforward and varies with age and substances used. MRI is a diagnostic marker of individuals with chronic alcohol abuse. Frequently, there is cortical thinning of the white matter and enlargement of the sulci and the ventricles. With HIV infection, some individuals presenting with HIV infection develop a neurocognitive disorder, generally showing a subcortical pattern with predominant impaired executive functioning, slowing of processing speed, problems with more demanding attentional skills, and difficulty in learning new information, but few problems with recall of learned information. Mild or major neurocognitive disorder due to HIV infection is usually more prevalent in individuals with prior episodes of severe immunosuppression, high viral load in the cerebral spinal fluid, and indicators of advanced HIV disease such as anemia and hypoalbuminemia. Depending on the stage of the disease, approximately 1/3 to over 1/2 of HIV-infected individuals have at least mild neurocognitive disturbances, but many individuals do not meet full criteria. Neurocognitive disorder due to HIV infection can resolve, improve, slowly worsen, and clearly it has a fluctuating course. Prion disease, Parkinson's, Huntington's, medical or multiple etiologies. So with prion, the classification of the major or mild neurocognitive disorder due to prion disease belongs to a group of subacute spongiform encephalopathies. This include Creutzfeldt-Jakob disease, variant Creutzfeldt-Jakob disease, Kuru, and fatal insomnia, among others. These can be caused by transmissible agents known as prions. Typically, individuals with this disorder present with neurocognitive deficits, ataxia, and abnormal movements such as myoclonia, chorea, and dystonia. Prion disease may develop at any age in adults. Peak age for this Creutzfeldt-Jakob disease is approximately 67 years, although it has been reported to occur in individuals spanning anywhere from teenage years to late life. Diagnostic markers can only be definitively confirmed through biopsy or autopsy. With Parkinson's, frequent presenting features include apathy, depressed mood, anxious mood, hallucinations, delusions, personality changes, rapid eye movement, sleep disorder, and excessive daytime sleepiness. Onset is typically between the 60s and 90s. Environmentally, risk factors for Parkinson's disease include exposure to herbicides and pesticides. Parkinson's disease may coexist with Alzheimer's disease and cerebrovascular disease, especially in older individuals. Huntington's. Progressive cognitive impairments is a core feature of Huntington's disease with early changes in executive function rather than learning and memory. Cognitive and associated behavioral changes often precede the emergence of the typical motor abnormalities of bradykinesia, which is a slowing of the voluntary movements, and chorea, which is involuntary jerky movements. Associated features include depression, irritability, anxiety, obsessive-compulsive symptoms, and apathy. Psychosis is rare but can be associated with Huntington's disease and often precede the onset of motor symptoms. The average age of diagnosis is approximately 40. Although varies widely, genetic testing is the primary laboratory test for the determination of Huntington's disease, which is, an autosomal dominant disorder with complete penetrance. Medical or multiple etiologies. So there are a number of other medical conditions that can cause neurocognitive disorders, including structural lesions, hypoxia related to hypoperfusion from heart failure, endocrine conditions such as hypothyroidism, hypercalcemia, hypoglycemia, nutritional conditions, for instance, deficits of thiamine or niacin. There's infectious conditions such as syphilis or cryptococcus, immune disorders, hepatic and renal failure, metabolic conditions, and other neurologic conditions such as epilepsy or multiple sclerosis. Unusual causes are central nervous system injuries such as electroshock or intracranial radiation are generally evident from one's medical history. So remember, these conditions aren't necessarily solely classified as mental health disorders because there can be so many other conditions that surround it, injuries and things like that. So they don't kind of classically fall into some of the, what we consider to be some of the major risk factors or etiologies for mental health conditions.